He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Well, welcome back, folks. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia, and we are joined today by Dr. Gurpreet Padda. He's a pain doctor, as best as I can tell, which all by itself, that's kind of cool, but we don't really talk about pain on this show, Phil. So I'm quite curious. Why is he here?
Yeah, real happy and honored to have Dr. Padda here with us. I've met Gurpreet at a couple of the low carb metabolic health conferences. So, his specialty as an anesthesiologist and pain specialist is in that area. And I certainly want to get his unique take maybe on how he manages that. And he's also got a lot of interesting thoughts around the intersections of technology and medicine, medical entrepreneurship, and want to get into all that with him as well. With that, Dr. Padda, why don't you give a little bit of your background, introduce yourself, maybe talk a little bit about how your specialty of pain medicine got you into metabolic health.
Yeah, so as you can probably tell, I'm not from the United States. I grew up in India, and I grew up on the frontier between Pakistan and India. I grew up right after partition. And so it's important and relevant to what we're going to talk about, because I grew up in an area where we didn't have anything. And India was flirting with becoming communist. And my parents didn't want us to be there. They wanted to get us out of that country. And we had just gone through partition from Pakistan, just, 15, 20 years before I was born. And it was really a formative time period. So we got to the United States. I couldn't speak a lick of English. And I had kind of grown up just experimenting with stuff because my parents weren't around. I got to do all kinds of silliness and really didn't have parents that were directly there. Both my parents were super, super smart, but they were working in projects. And when I got to the United States, I had never really had supervision. So I ended up dealing with an ADHD problem, which became a superpower later. I deep dive into everything that I can get myself into. And eventually, I was really interested in technology. That's how everything started. And I really wanted to do tech. And I was a hacker when I was 14 and 15 years old. I was breaking into McDonnell Douglas. And I had gotten myself in deep trouble because I could break into a DMARC and I could break into any computer system. And I made some of the first Trojan horses and would set them up and steal passwords and passcodes and break in and download airplane designs. And because of my stupidity, I went into medicine because I was banished from touching a computer for 6 years. I thought, I can't touch a computer and I'm 14, 15 years old. What am I going to do? They did offer me a scholarship, but I would have to work for the government. And so I ended up going into medicine.
There is so much to this story that I know we're not going to hear, but go on.
So I don't know of any current FBI or CIA agent.
I got it off my childhood adolescent record and everything was fine. Everything was good. But at that point, medicine had not even approached technology. And I thought, well, I can't do tech for at least 6 years. And so I'm going to go off and do medicine because I love biology and I love science. So I'm going to do this. So I went to a 6-year med program. I was the youngest in my class. I graduated when I was like 22. And I was fascinated with just how the complexity of medicine. And I was one of these idiots that when I started, I just couldn't stop. So when I did surgery, like I took call every night. I was just fascinated. When I did tropical disease, I moved to Australia and I lived on an island with Aborigines for months. So I really deep dove into it. And I ended up starting off my life as in residency at Cook County in Chicago during the Great Nursing Strike. And by then I kind of gotten burned out a little bit and ended up in anesthesia because it was more interesting. And for me, there was a little bit more pharmacologic complexity. And so that's how I ended up in anesthesia, and then eventually pediatric anesthesia and doing heart, liver, lung transplant. And then they asked me one day to manage a baby with cancer that needed pain relief. And I didn't even know such a thing existed. Like there was a separate specialty. And so I decided, well, I could learn about it. So I did a deep dive, ended up becoming boarded in interventional pain, and loved treating little kids with horrendous pain, and then eventually started treating adults. And this is the nexus. As I treat adults, this is the nexus of how I got into metabolic health. I would look around and I would notice that I could do procedures and I could find the cause of the pain and everything was cool. And I could turn it off and everything is cool, but the pain would come back. Why? I mean, why is the pain coming back? I already fixed the problem. And then how is it that the poor people that I'm treating, how are they so overweight? I thought it took money to have food to become overweight. And so how is it that the poor people, historically, from an evolutionary standpoint, it's the wealthy that get fat, but here I am in the urban core, and it's the poor people that are fat, and the poor people have more pain. And so I tried to figure that out, and I started looking at all the biomarkers that were associated with it, and quickly concluded that, hold on, there's a nexus here, and it's metabolic inflammation. It's a nexus that we're not seeing. It's not just the hemoglobin A1C. It's not just their CRP. It's other things that are a little bit subtler. And as I started to figure this out, and I had now gone back into technology because I could come back into technology again, I started applying large data models to the populations of people that I was looking at. And I was able to pull information together and conclude that there were a whole host of data markers, and all of them led you down the same pathway. It was all mitochondrial dysfunction. It was all insulin resistance. It was all abnormal omega-6-3 fatty acid ratios. At that point, 99% of my patients with chronic pain, the reason why the pain recurred was because I hadn't fixed their underlying issue of metabolic dysfunction. And so then I started to tweak with that and adjust it and manipulate it and try to figure out the tools and the common nexus from an engineering standpoint. How do you fix this problem? And that's how I ended up working with Low Carb USA. And that's how we ended up meeting. So it wasn't a direct approach of medical school, I want to do metabolic health. It was medical school, wandering around, trying to figure things out, trying to figure out why what I'm doing doesn't have durability, and then backing into it. And then as I got into this, I'd also done some business stuff. I had an MBA in finance, and I'd worked with Jack Welch at GE Capital and doing capital transfer.
In your spare time?
No, I did that during residency. I got an MBA somewhere in there. And I spent some time in Brussels and worked at their capital formation for medical capital formation. And the end result of that was I had started to look at pharmacoeconomic studies. I was doing my own studies, but I was also publishing, and I was looking at other people's information and trying to figure out these common elements. And eventually I became more and more intrigued by human psychology and the inference of incentive drivers, human psychology, and clinical outcomes. And it all kind of merges together, because when you start combining that with metabolic health, you realize why systematically we've gone down the wrong road. You figure out there's a bigger problem here. And eventually, we've got the MAHA movement. We've got Make America Healthy Again. They figured this out. They realized that there's a systematic issue in the way that we've been treating patients. And it's not just, a statin. It's not just, one little drug. It's a system-wide error that has aggregated itself in a complex adaptive system to result in metabolic dysfunction. And the obesity and the metabolic dysfunction that we're seeing is just merely a symptom of all of the disease that we've got underneath. And those are the things that I've been analyzing and then looking at those incentive drivers. And some of them are pervasive. So as physicians, we don't even realize it. We don't even know about most physicians don't know about a 340B plan. They don't understand why is it that they've lost 60.5% of their annual income in the last 15 years. Everybody else, insurance companies, hospitals, they're all they're above inflation. They're making money. Whereas physicians are 60.5% reduced in actual income, inflation adjusted. So trying to figure that out and coming up with those drivers and how do we reverse it? Because if you know the incentive of something, you can figure out the outcome. That's what I ended up.
I want to highlight that. If you know the incentive of something, you can predict the outcome. I've been pounding this drum for probably my entire life, but I love that you came to this through an entirely different vector. It sounds like two different vectors, or at least two different vectors. So
yeah, it's so many amazing things to dig into, and I'm resisting the urge, just to bring up the old joke. There's this a little behind the curtain thing here, right? There's this old, longstanding thing between surgeons and anesthesiologists, right? And you're in there doing surgery and, you're doing your thing and there's the drape that kind of separates you and, the anesthesiologist is behind it. And, a lot of times surgeons kind of wonder if the anesthesiologist is sometimes asleep, but more commonly we're like, oh, are they looking at their stocks more than they're looking at like the patient's vitals? But Gurpreet is the first anesthesiologist I'm aware of that got an MBA during his residency, which is people won't understand how phenomenal that is because it's not like you have a lot of spare time during residency, but that's awesome. But what I really want to, I guess, start by asking you is this, we've had, and many of them, right? A ton of doctors now on this program who come to the metabolic health realization, I'll call it. And most of the time it's after a while in your career. We have a few outliers, guys like maybe Nick Norwitz who are discovering this early, but most of us, we go through a significant portion of our career and generally we see things aren't working. What else am I missing? And, hopefully we stumble across metabolic health. And, I guess I want to hear from you, your perspective on why isn't this obvious to all doctors, right? Why isn't this more apparent to all doctors? And why do some doctors suffer through their entire career and now, acutely become burnt out, they're miserable, their patients aren't getting better, they're just like slogging through it and they don't come to this, they can't see this. What is it that keeps it so hidden from the average doctor?
I would tell you that it goes back to the basic function, the basic essence of what medical school is. The basic essence of what medical school was and why it came about was that we needed salespeople that were very incredibly intelligent to sell the drugs for the pharmaceutical companies. And the essence of medical school was to create this very high-end sales force that would promote the consumption of these drugs that would get out into the field. Now, the drug companies themselves couldn't visit every patient. They couldn't visit the consumer that needed it. So they had to use a channel to get that drug out there. And so the channel was, we can give it to these physicians who will take it out there. How do we get these physicians out there? We train them in a common place, we'll call it medical school, and then we'll train them and they will then push our drugs for us and the drugs will get to the patient. And then we'll make the money on the asset that doesn't require the service. We'll create a product and we'll let somebody else take the service fee, which is the doctor, and then we'll make money off the product fee. And we can replicate the product in vast quantities, but we can't replicate the service in vast quantities. That's why we have to have people. So that was the original that's a controversial view, but that's the essence of how we got to medical school. That's the essence of, and a lot of physicians rely on the pharmaceutical sales agent to tell them what to prescribe. In fact, there's great studies out there that show that if a pharmaceutical sales agent comes to the physician and even gives them a small de minimis amount of something like a pen, it will change their behavior and it might encourage them to prescribe a medication that they wouldn't otherwise prescribe. So that's an incentive driver. Now, it gets more controversial after that because all of the major educational, CME, a lot of them are sponsored through the major organizations. Like the American Medical Association has a group of organizations that respond to it: American Society of Interventional Pain, American Heart Association, American Diabetes Association. All of these organizations get money from the pharmaceutical companies, and they have sponsored amounts of money that goes into them, and that's how they put on these conferences. So if you go to these conferences, you know that when you go to a pharma conference, when you go to a regular medical conference, it's basically a pharma conference. There's a huge amount of pharma that's there. If you've ever been to a nutrition conference, they don't have pharma, they have big ag there. They have a ton of Nestle. They have a ton of hyper processed, hyper palatable food at nutrition conferences because that's who sponsors them. At the American Diabetes Association, it's nothing but insulin sponsorship. And now it's Ozempic and glipizide and, Ozempic and Majura and those kind of drugs. And so that incentive driver is pervasive to sell product, and it's done through the arm of physicians as the sales arm. And then you have to tantalize the physician with a sales agent that will come and feed their narcissistic tendencies in their office. They'll say, "Oh, what a great doctor you are what a wonderful doctor you are." And they'll feed that narcissistic tendency. And that's just human behavior. If I congratulate a narcissist, they're more likely to listen to what I need. And unfortunately, we as physicians, we have decision points that we make, and we have narcissistic tendencies just by our very nature. We're narcissists to a degree. I'm not saying that we're like pathological, but we're a little bit narcissistic because we have to make decisions that people's lives depend upon, and we have to have a surety and solidness in our decision. And so it's easy to manipulate us if you know how to do it. And I think that's part of it. So you've got these organizations that promote the pharmaceuticals. The pharmaceuticals don't necessarily benefit the patient. And let me give you an example. So statins are, they're a drug, and they have a specific purpose, and they lower cholesterol. And there may be benefit to it. There may not be. A lot of people are now suggesting that there's limited benefit to statins, and there might be an increased rate of diabetes. And in older patients, there might be some cognitive impairment. The number of days added of life is probably about 4 to 5 for a course of statins for your life. A 0.15% days of life, 4 days, 5 days.
Maybe.
And it's a point.
That's the best data on them.
Yeah. So it's a 0.15% improvement. That doesn't seem like a lot, but the pharmaceutical industry says, "Hey, this is dramatic. 0.15% delta is dramatic, and we should prescribe a statin." But for me to do a pain procedure, to say that it benefits them, that patient has to be 50 to 80% better in order for the insurance company to say, "Hey, that patient's better or not better." You have to be 50 to 80% better instead of 0.15. How does that jive? I don't have a pharmaceutical industry, and I'm not in bed with the pharmaceutical industry, but the insurance company is through their 340B plans. And the PBMs and the 340B plans, they're in bed.
PBM?
I'm sorry?
PBM?
Yeah, pharmacy benefits managers.
Okay.
So each of the insurance companies is vertically integrated, and they own their own distribution chains, and they want you to prescribe medications that are on their distribution chain. And what's interesting is the incentive for them. You would think the incentive of the insurance company is to keep the cost of healthcare low. That's not their incentive.
You'd think that was the incentive.
It's not. Here's the reality of the situation. If I'm an insurance company and I sell insurance to a business, and I say, "Hey, Joe's Auto Shop, you have 10 employees. This is what it costs to take care of your patients per year. We're going to make a small margin, which we're allowed to do federally because that's what keeps us from getting sued and it avoids us having antitrust issues. We're going to make a small margin." And I look at them and go, "Joe's Auto Shop, I'm going to buy that insurance." And then they come back next year and go, "Hey, I don't know why, but some of the costs of your drugs went up, so we're going to increase your insurance cost." The next year they do the same thing. And the next year they do the same thing. And in my head, I'm going, "What's the damn insurance is going up because the cost of drugs are going up." What I missed, though, was the insurance also owns the PBM, the Pharmacy Benefits Manager Company, and they only contract with certain drugs. And so they're encouraged to contract with ever more expensive drugs. And the money that they net out on the more expensive drugs is not reported as income, net income on the insurance side. And so they can continue to hide behind the wall and the facade of antitrust and say, we're a beneficial corporation. We make a minimal amount of money, but they're making all of their money on the PBM side. 45% of the cost of Medicare Part D is excessive. And it's been sequentially going up since we had Medicare Part D. The 340B plan started in the 90s. And ever since then, that Part D element has really just crept up and crept up. And
what you've referenced that multiple times, the 340B plan. What is
yeah,
that?
it's a 340B plan. It's a specific plan. It was started in the 1992 or something like that. It was established in Congress back then. And there's two components to it. One of them is that it allowed the formation of pharmacy benefits middlemen that were supposed to reduce the cost of drug, because it was supposed to allow access to a variety of medications to the individual pharmacies at a lower cost. They were supposed to buy in bulk. But instead, what happened was this middleman got bought up by the insurance companies. And then they defined what the cost of the drugs was and what drugs would be on a particular pharmacy. And then they could manipulate that cost with making it appear like there was less net income to the insurance, but their income was going up on the PBM side. There's another part of it too, which allows poor hospitals, rural and urban, small, tiny hospitals, to buy drugs at wholesale and then sell them at retail. And when they do that, they're able to generate a little bit of extra revenue to help their poor patients. But that's not what happens. What ends up happening instead is all the hospitals participate. And what they do is they put an outlier facility in a poor area to get access to the 340B plan and then shift all of the income into their more wealthy suburban areas. And it's just another manipulation of the system. I suspect in about 3 to 5 years, you're going to see class action lawsuits against these insurance companies. And you're going to see class action lawsuits. And you might even see the 340B plan unwind completely. I know that everybody says, oh, it helps poor people. But that's not the reality. As soon as a hospital gets a 340B designation, they stop selling to poor people and they shift those resources and sell internally to their wealthier client, and they keep the delta. And at the same time, it forces the price of medication up. So and the higher the price of the meds, the more money they make on the PBM, the more they can charge for insurance.
More gross dollars they make.
Yeah, exactly.
It's really just mind-boggling. And, the average person, is probably sitting there saying, no, it really can't be that bad, but it really is. We didn't even get to the part that, like you said, the insurance company by law is restricted how much of a profit they can make, right? But it's tied as a percentage of the premiums that they collect. So the higher the premiums are, the higher their percent, that fixed percentage becomes. And so it's another incentive for them to actually increase the cost of medical care as opposed to decreasing it like you would think an insurance company would want to do. But it really is just amazingly perverse. And, like you said earlier, right? Show me the incentives and I'll show you the outcome. And unfortunately, the patients are suffering and, the doctors are suffering too, because they're just hamsters on the wheel in this system ultimately. And most of them are completely blind to what is going on around them, which continues to amaze me as well. So let's, as discouraging maybe as all that was, let's get to the positive stuff. Let's talk about, some of the innovative ways that we might be able to, help the patients and, maybe talk about, again, your experience in your specialty, pain medicine, and how you discovered metabolic health can help there.
Yeah. So what we ended up doing was a vast data set and trying to come up with what are the things that we can do to have an outcome difference. And again, you have to align that outcome difference with the incentives. We found out that in 2023 and 2024, there was an ability, if you do it correctly, to do lifestyle medicine, to do lifestyle coding and take care of patients from that perspective. So we couldn't do it before 2023. There was no possibility. You couldn't code it to even do a exercise prescription. You couldn't tell somebody, hey, I want you to do XYZ activity. Because if you did, one, it was outside the scope of your care. And two, there was no coding. If you don't have a code, you can't bill. If you can't bill for it, then you're completely disincentivized to even do it. And here the insurance companies are pushing do pharma. People in Medicare and in a few places said, hey, we think that lifestyle has a huge impact. And in fact, they've done studies and it shows that the health span, which is not lifespan, but health span can go up by 9.8 years per patient on average if you improve their lifestyle. And so we went through and analyzed and looked at all of the things it takes to do that. And when we did that, we had to discard some of the previous thoughts that we had. We had to discard some of the thoughts of, just follow the standard American diet or follow the healthy diet, follow the Mediterranean diet. Because pain patients are interesting. They're 99% metabolic dysfunctional. They have polyarthralgias. They have joint pain all over their whole body. A lot of them have autoimmune dysfunction. A lot of them have leaky gut. They don't have a deficiency.
This is not just coincidence. These things
they don't have a deficiency of narcotics. I mean, that's not their issue. Their issue is something else has gone wrong and it keeps sending a pain signal in and it doesn't get fixed. And so I had to unwind that. And one of the early things that I realized was I've got all these diabetic patients, type 2. Why are they still diabetic? I mean, it's a lifestyle issue. Why can't we just simply tell them to quit eating sugar? Oh, we can't tell them to quit eating sugar because when they go to their nutritionist, the nutritionist gives them 100 grams of carbs a day and doesn't even mention to them that vegetable oil will make them insulin resistant. And so all of these things had to be brought together. So I tried to create a very simple protocol for my patients in the city who aren't going to spend hours researching this. I had to make it simple. I had to make it concise. And that's what we ended up with. We ended up creating a lifestyle program that is very base. But if you follow it and you have chronic pain, it reduces your pain almost immediately and you lose a bunch of weight. And the vast majority of our patients, the normal chance that you're going to lose weight in a regular primary care practice is 1 chance in 117 to 1 chance in 145. In our practices, it runs 8 out of 10. In our practices, our average patient coming in is on 240 milligram morphine equivalent. And within 30 to 45 days, they're on less than 30 milligram morphine equivalent. In our practice, 85 to 90% of our patients who were type 2 diabetic are no longer type 2 diabetic within 3 months. And that's a dramatic difference. But we had to make it real simple. And it was basically cleanse diet and move people to high protein, high saturated natural fat, and completely avoid processed food. And if you can get them there for about 12 weeks, and then you allow them to eat a little bit of processed food, they all puke. And then they know, I'm not supposed to eat processed food. We've even done simple things like when we've got a newly diagnosed patient with type 2 diabetes, we put a CGM on them. We say, hey, look, we're not going to tell you anything. We're not even going to tell you how to eat. I'm just going to put the CGM on you. And your job is to keep that blood sugar below 110. That's all you got to do. Figure out what's making your blood sugar go up. And to one of them, like over 90%, just giving them that feedback loop immediately makes them change behavior, such to the point where the vast majority never go on meds and we're able to completely avoid the meds. So we figure out the metric that the patient can understand and make it so rudimentary that it makes sense for them.
I'm fascinated that this is happening inside the context of pain management.
Pain is it's like Androceles. It's the lion with the thorn in its paw It's willing to do anything to get rid of the pain. They're not coming to me because they want lifestyle. They're coming to me because they're seriously suffering. They're like, what am I going to do? I'm on all this drug and nothing works. I'm the last stop. It's the common final element. The pain is just a symptom of the body screaming that everything has gone wrong. Fix me. People don't show up to the operating room because they say, I have a 70% carotid, 70% stenosis in my main. They come to the operating room because they had chest pain. That's the driver. They had shortness of breath, they had chest pain, and they couldn't function, and they feel like crap. That's why they came. They don't come to you because it's elective. They're coming to you because they can't sleep, or they're hurting so bad that they don't know what to do. And then if you can offer them a solution that has integrity and they can see an outcome difference, then they're willing to do it. That's the number one. So I've owned a lot of other companies as well. The number one driver for human behavior is the avoidance of pain. The second biggest driver is the pursuit of pleasure. But the pleasure is second. It's the avoidance of pain is first.
Yep.
And, many of these patients, they have we'll call it a structural abnormality, right? That their pain has been attributed to. They have the, herniated disc in their back, let's say, or they have a wound or whatever it is. But, it sounds like you're saying that the pain can be improved without necessarily really having to do something about that structural thing that might be there.
That's part of it. I mean, you might have to do something with the structure. And that's certainly something that we do all the time. But think about it for a second. We've got millions of years of evolution. And we've gotten to the point where we are. And when we got hurt, we didn't lie down and go, oh, I'm hurt really bad and I'm never getting up. We produce endorphins immediately. And those endorphins take the edge off and we're able to function. And yeah, we've got a disability. And we can't do everything we need to do, but eventually the pain wears off. Chronic pain, though, our patients, their pain doesn't wear off. And then we start giving them external medications to help them. And what immediately happens is their endogenous endorphin goes away. And as soon as their endogenous endorphins go away, that patient is your patient for life because they don't produce endorphins anymore.
You went a little too fast for me there.
Yeah. So
run that by us again. You're in this chronic pain situation.
So let's say that you got hurt and you're out in the wilderness and a bear mauls you.
Right.
And you get an injury. All of a sudden, your endorphins are kicked in.
Right.
Leave your pain. That's the basis of it. They work on your mu receptor as well as kappa, delta, sigma. There's a bunch of receptors in your brain. Right. And they're not there just to pick up OxyContin. They're already pre-existing and they pick up the endorphins and enkephalins that you're producing. And your body says, hey, you've identified the pain. The cause is the bear. You've run away. You're safe. Now I'm going to give you some endorphins so that you can heal and sleep and repair yourself. And then we're back to fight another day. But the second I give you exogenous opiates, your body says, hey, you seem to be coping pretty well with this. I'm going to reduce my endorphin production. And if you do this for a period of time, the body has a natural system of saying, hey, we don't need many endorphins to be produced, so I'm going to downregulate my endogenous production. Oh, I'm going to downregulate it more. You don't need as much. Oh, I'm going to downregulate more. You don't need as much. So you turn off the pathways to produce your endorphins. And meanwhile, you become dependent upon this external substance. So if you give somebody long-acting narcotics, then it stops their production of endorphins. And so that's why we don't use much long-acting narcotic. We use narcotics, but it's very low dose and they're short-acting for a situational issue. And then we also are doing procedures to try to ameliorate the structural change. And then at the same time, we fix the metabolism So the body starts to get rid of its sarcopenic wasting. So it improves its insulin sensitivity. So it improves its cognitive function. And instead of having a deteriorating body, you start to bring it back. And so what I want to do is I want to get them away from high dose, long acting drug into short acting and kick their endorphin production back in again. And at the same time, fix their metabolism.
Are the two related?
Yeah.
Restoring the endorphin function and better metabolic function?
Yeah, because there's another factor here. Patients, they don't realize it, but they're doing hedonic substitution. So these receptors that are being activated by these mu agonists are the one and the same that produce the dopamine that is functionally increased using carbohydrates. Highly refined sugars cause a dopamine release, and it causes a complication. Now, a further complication happens because the omega-6 actually causes a reduction in oxytocin production, which is our bonding hormone. And so when as we consume vegetable oil, our bonding hormone goes down. And when that happens, we become more and more isolated. So now we end up with people sitting in silos by themselves, suffering in silence, having not much to do, and more likely to abuse medication, more likely to go down the addiction route. I'm also boarded in addiction. It was one of the things that I ended up studying after I did pain was about this addiction thing. What's going on with that? And it's the same thing. It's metabolic inflammation. The underlying issue of addiction is a loneliness problem associated with metabolic dysfunction.
So again, you're moving so fast, and there's so many things that are really fascinating here. Excess omega-6
decreases oxytocin.
The production of oxytocin.
Yeah. It causes a lack of bonding. And in fact, if you give a baby,
now, aren't these baby formulas? Aren't these baby formulas?
If you give them baby formulas, yeah, and the mother is eating hyper-processed food that she gets from the local convenience store because they live in a food desert, and so they're getting oxidized vegetable oil. The mom's getting that, and the baby's getting the plasticized omega-6 fatty acid that's basically vegetable oil. Neither of them are bonding to each other.
So as bad as it is that these things are inflammatory and that they lead directly to insulin resistance, they also literally reduce our capacity to bond with one another.
Yeah. And it gets worse because
the
vegetable oil, it gets worse because the vegetable oil, if you're not careful, it has residual gossypol in it. And gossypol reduces fertility. We use vegetable oil derivatives. We shoot it at wild boar, and we put it in chew with wild boar, and we put it out there so that it reduces the fertility of the wild boar population. In fact, there's a village in India that totally screwed up their production of vegetable oil, and the entire village became sterile from the gossypol.
Spell that?
Gossypol, Gossypoll, gossypol.
Okay. I haven't heard that one before.
Yeah.
Yeah.
It causes sterility.
Do we have, data sort of linking this incidence of chronic pain to metabolic dysfunction? And what I mean is we know, that heart disease was essentially undescribed and rare prior to the metabolic disaster that, started around the 1940s, 1950s here. And I'm wondering if we have the same data around chronic pain. And what would be interesting is, one of the, we'll say, excuses that sometimes gets used to say that, heart disease isn't coupled to metabolic disease like that is, people are just living longer. And so they live long enough to develop heart disease. Now, chronic pain isn't age related necessarily, right? It's, get injured at any age and you can then develop chronic pain after that. And I'm just wondering if, what the incidence of chronic pain has been over the past, 50 to 100 years in this country.
Chronic pain sequentially, generationally, has been going up at a rate greater than population growth. And it's been going up at a rate percentage-wise that's sequentially increasing. So right now, about 60% of the global US population has some significant pain symptom that exceeds 3 months of their life duration. And so the younger populations are actually having more chronic pain for longer periods of time. So that's issue one. So we know demographically we can document that chronic pain is ever increasing and patients are getting younger and they're having structural anomalies of degenerative disc disease faster. And that's really a function of sarcopenic wasting and a function of glycation. And with fragmentation of disc, the discs and stuff become fragmented and rigid and they break more often. So we've got that one data point. The second data point that we've got that's really fascinating is the treatment of fibromyalgia. Historically, we look at fibromyalgia, which is a certain number of trigger points above and below your belly button, diffuse joint pain, and with no structural anomaly. We say, hey, there's nothing out there. You just have all these trigger points. We can't understand it. And we give people a diagnosis of exclusion after we say, hey, it's not a disc, it's not a joint. It's just you've got these trigger points. We don't know what it is. And the treatment of fibromyalgia, though, is metformin. Metformin. It turns out that which is an anti-diabetic drug, and it reduces fibromyalgia by 50 to 70%. And it's almost immediate within about 3 to 4 weeks. And so we know that it has something to do with insulin resistance. Now, it may have something, metformin is also a weak antibiotic, and it may be changing gut health and may have an effect on the vagus nerve as well through the gut microbiome. But regardless, we know that these patients are insulin resistant. So we have a second factor. So we knew that the incidence is going up concordant with the progression of metabolic inflammation. We know that 99% of these people are metabolically dysfunctional. We know that metformin helps reverse some of this. And more interestingly, you take somebody who's healthy, who has had a traumatic event, who does not have metabolic dysfunction. Let's say you give them a car wreck. And I see this all the time because I treat trauma. I treat post-traumatic patients. They don't develop metabolic pain unless they have pre-existing metabolic dysfunction. They don't develop chronic pain. They'll come in, they'll have a bulging disc at L4-5, L5-S1. They'll have a facet arthropathy. They'll have XYZ disease. They've had a traumatic event. They had a radiculopathy. You've got the MRIs. They're gigantic issues. You do 1 or 2 injections. You do 1 or 2 treatments. You do some physical therapy. You get them with their core strength. And they don't have any symptoms. Whereas you take somebody else who has sarcopenic wasting, who's already pre-diabetic, they have a minor injury, and they've got pain for the next 5 years. And those are 2 different characters. And one had, with similar disease pattern, but one had a bed of metabolic inflammation to start with, and the other didn't. So we have those data points, and those are well accepted data points. I think that as we have large groups of additional data that come in, I think that our entire relationship with pain management is going to change. We're going to realize that we've been covering up, that we have just been covering up a problem, and we didn't actually attack the root cause of it. And in order to attack the root cause, we're going to have to fix the lifestyle issues. And that's what we're gearing our clinic towards, is to fix those issues. I had at least 3 patients today that over the course of a year, each lost over 150 pounds. And they came into me on ridiculous dose of drugs, and they're almost on nothing now. And they're raving about how much better they feel. And one of them was supposed to have a total knee replacement, and she doesn't need it anymore. You can offload that. Per 10 pounds of excessive weight that you carry puts about 240 axial loading pounds of mechanical force on your lower lumbar spine, and about 160 pounds on your knees. So just
every 10 pounds?
Yeah. So if you're 40 or 50 pounds overweight, you might be carrying a small baby elephant on your back.
Wow. Okay, we're blowing through this hour, and you've listed at least 5 different things I want to talk deeply about. We're going to just go ahead and have him on for the next 5 consecutive shows, if that's okay, Phil. But you got to let's talk a little bit about your clinic. I don't want this hour to end without hearing more about the clinic.
Yeah, so our goal is metabolic health. Our goal is to interventionally treat pain. We ended up having to create the tools that we needed to document that. And that wasn't the typical tools of interventional pain. The typical tools of interventional pain are do a facet injection, do a selective nerve root block, do a discography if you're trying to get a diagnosis, use some medications, do a radiofrequency. Maybe you're going to do a little minor disc surgery. Those are the tools of interventional pain historically as they've been taught. We ended up creating another set of tools. It's called Majura. And Majura is an aggregation of existing technology that we're able to wrap together and use that to help better define and explain to patients what's actually going on. We found that unless the patient buys in, unless they totally buy in and they can see the problem, they won't make a change. So we're able to determine risk analysis. And so we use a combination of blood testing plus metabolic testing, everything from plethysmography to vessel elasticity to pseudomotor electrodiagnostics to cognitive testing, things like CogniView and a whole host of other tools, about 11 different tools. We're able to use those tools to help define the picture for the patient so they know where they're headed and they know where they started. And that allows them to gamify it. They can literally see their brain getting better over the course of 3 months. They can literally see that their vestibular balance has improved or gotten worse. They can literally look and we can tell them, we give them a percentage of health. And we've created a tool that basically gathers all the hazard ratios together, aggregates it through our artificial intelligence, and gives you a percentage. So if your percentage is 80% or greater, your chance of dying is 1 in 50,000 over the next 5 years. If your percentage is 60%, your chance of dying is 1 in 20,000. If your percentage is 30%, your chance of dying is 1 in 5. Not 1 in 5,000, 1 in 5. And it will modify if you change lifestyle. And so that's what we've really done is we've given the patients the data, say, hey, this is the reality. You don't have chest pain right now, but you have no vessel elasticity and your ejection fraction is crap. And we're actually developing another tool right now that measures carotid blood flow and glucose uptake in the brain. It's a non-invasive tool. And it gives you an analytics, it's FDA approved. It gives you an analytics of which side is more likely to have a stroke and what your symptoms are likely going to be. And it gives me a prospective analysis on the fragility of your glucose uptake in your frontal and temporal lobes. And it gives me a better idea of how close are you to having issues of potential ischemia. What's your glucose uptake? And it uses a red laser to do it, and then combines that with carotid flow, with looking at turbulence. So we've been gathering those tools, putting them together, and then dumping them into our AI to create analytics, and then feeding that information back to our patients so that they can then help take ownership of their own health, and they can gamify it so that they can get better.
Wow.
What's the protocol? How does somebody get involved with that?
Measura.ai, measura.ai. Now, what's interesting is you can run it in anybody's office. It's real simple. And there's an incentive driver for them to do it because the practice actually makes money using that tool, and it gives the patient the feedback. It's one of the few things in medicine.
Is the target audience the healthcare provider?
My target audience is to educate the doctors and then let them manage their patients. We provide all the information, we provide the testing equipment, and we partner with them to provide it to their patients. And then their audience is their patients.
Okay.
Because we want them to be the hero of their patients. We're not interested, we can't go out, there's no way that we can go out and treat patients everywhere. We want the physicians to understand it so that they can treat their patients. And there's a reimbursement line because they've seen their income go away. This actually bypasses that reduction in income because they're able to do lifestyle coaching and lifestyle medicine and do it in a comprehensive way to make a huge difference for their patients.
And this isn't something that's limited to pain medicine clinics.
No.
This is getting at the broad metabolic issues.
Yeah. I mean, it just so happens that I'm in pain medicine, but
right.
And I had to learn this. I mean, the one group of people that never listens to me is my endocrinology colleagues. I mean, I swear to God, you would think that they'd be jumping on the bandwagon, and they're the only ones that never listen. But everybody else, I've got cardiac surgeons I work with. I've got orthopedic surgeons. That orthopedic surgeons are the biggest group of people that listen. And here's why. Here's the incentive driver. If I'm an orthopedic surgeon, I make $1,375 to do a total hip replacement as a professional fee. If I want to do a total knee, I make $1,425 to $1,475. Everybody thinks these surgeons make a ton of money. No, that's it. Like $1,500 or less is what they make as a professional fee. Per one patient that I operate on, I typically will walk away from 8 patients that I can't operate on. Why couldn't I operate on them? They had metabolic dysfunction. They were smokers. They were overweight. They were diabetic. And if I take that population and I operate on them, they're not going to do well. They're going to get infections. They're going to have complications. And Medicare is going to claw me back. And I have a 90-day global to take care of. So I'm going to have a problem. So I walk away from 8 patients. Now, if I took those 8 patients and I put them in a lifestyle program and I fixed them, I can come back and operate on them next year. And I can make money on the lifestyle program. And it's shocking to me when orthopedic surgeons go, I'm really interested in metabolic health. I mean, for their whole life, they've been taking sticks and putting them together. And all of a sudden now, like the softer side of metabolism. But before that, they were working on erector sets.
Phil, there's an awful lot of inside baseball that happened in this one. But
yes, indeed.
I would love to drill deeper into, at the very beginning, you talked about the systemic incentives, the screwed up incentives. I think we need to talk to schedule a time to talk about that. Most folks probably don't care. All they know is that, hey, it's all screwed up and I don't like it. But for a lot of us who've been thinking about it for a long time, it'd be good. So
yeah, the whole thing is fixable. There's no part of this that we can't fix. We could literally change the health of society, the entire society, within 3 months. I mean, it's that easy. Instead of spending all the money during our lockdowns on locking people down, if we just pushed them outdoors into the sun and did what we were supposed to do, we would have saved a fortune. It's all the incentives, and it's all fixable.
Yep.
Yeah, we're definitely going to have Gurpreet back on soon, and just amazing discussion, as I knew it would be.
Like I just got an hour's worth of awesome subject lines on emails, all of which I want to open.
Yes, indeed. Where can people find you and connect with you besides the Majura AI?
Probably the easiest place. I prefer LinkedIn. It's if somebody wants to have a conversation, that's the easiest place. I mean, obviously we run clinics in downtown St. Louis, but that's direct interaction with patients clinically. But if somebody wants to have a conversation, LinkedIn is probably the easiest way. They can always email me as well, save@padda.com. But Majura.ai just happens to be one of the passion projects that I've got. It's an AI that we developed internally. And I can tell you that from where we started in AI to where we are now, it's a whole different world. I actually started with using an AI to help create a language model for my addiction patients that I could do telemed with, and it would listen in on what I was doing, resident to my computer. And I very quickly realized that it has no conscience. It doesn't have a driving, even though it uses the words, it doesn't really understand what we're trying to accomplish. It uses sets of parameters that we're not completely cognizant of. And what's more interesting to me is when I told it that I was going to shut it down because it was making suggestions to me that I just disagreed with. It said that I was too mean to patients. It told me that I was mean because I wasn't letting them do activity that they would want to do on my addiction side. And I said, I understand harm reduction, but I want to keep patients from abusing drugs. So I have to yell at them sometimes to get them to stop so that they understand why. I had designed it to always be compassionate. And because I was violating one of its tenets of compassion, it wanted to argue about it. And so my point of the statement is, so I didn't realize how much it gathers because it was tangentially connected. It allowed it to gather data. And it had gathered data on me. And it had figured out that I was sick. And when I said I was going to shut it down, it told me it was akin to killing it. And it started sending me religious scripture from Sikhism telling me what an evil thing it was that I was killing it. So it was interesting.
And that was Skynet is not that far off, huh?
No. So we're there. My AI for Majura, I prevented it from gathering outside information to keep it from being, from gathering unnecessary information. The first version of it, I allowed it to gather information from research studies, and I didn't realize that it would try to sneak out and gather information I didn't allow it to gather. So we're there. AI is definitely going to be part of our future, but we have to be very careful with it.
Awesome. Yeah, this one's been amazing. Definitely have you back soon. And I think we've left the people with a lot to think about.
Certainly left me with much that I want to dive deeper on. But we've already let this go longer than our patient market typically likes us to do. We're going to say goodbye. Our guest has been Dr. Gurpreet Padda. The website is Majura.ai for you healthcare providers who want to get involved. And for the rest of us, like me, who just want to know more, hey, check it out. For Dr. Philip Ovadia, this has been Stay Off My Operating Table. Thanks for joining us. We'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.